This PowerPoint is going to cover sensation. First, we're going to start with the discomforts of pregnancy and what we can educate the woman to do to relieve her discomfort. So in the first trimester, some common discomforts. The first one is nausea and vomiting. Nausea and vomiting is believed to be because of an elevated HCG level. Also changes in carbohydrate metabolism, and of course there's emotional factors as well. So we're going to teach them to avoid odors, eat dry crackers in the morning, avoid greasy foods and highly seasoned foods, drink fluids between meals, drink carbonated beverages, small frequent meals. They can use acupressure wristbands. And then there are some things over the counter like ginger, vitamin B6, and supplements like Unisom that can help. Next is urinary frequency. This is from the enlarging uterus that's putting pressure on the bladder. We're going to tell them to increase their fluid intake during the day, decrease fluids in the evening, and make sure to void when the urge is present. Fatigue. So fatigue can be caused by urinary frequency at night. Make sure that she's planning rest periods and asking for help from family or her support, and going to bed earlier as well. Nasal stuffiness and epistaxis or nosebleed. These are from an increased estrogen level that's producing edema. One of the things we can tell her is to use a cool mist vaporizer. Breast tenderness from increased levels of estrogen and progesterone. Really just tell her to wear a well-supporting bra. Increased vaginal discharge. Increased production of mucus by the endocervical gland. We call this leukorrhea. And it's from increased estrogen. So make sure she bathes daily and wears cotton underwear. And pyelism. So this is dry mouth. We're going to tell her to use astringent mouthwash, chew gum, and hard candy. In the second and third trimesters, we might start to experience some heartburn. So this is from increasing levels of progesterone, decreased gastric motility, increased relaxation of the cardiac sphincter, and displacement of the stomach by the enlarging uterus. So to try to prevent heartburn, eat small frequent meals, avoid overeating and lying down after a meal, and she can use low sodium antacids. All right, ankle edema. We've got slow venous return due to increased capillary permeability, increased levels of sodium, and especially happens in the cases of prolonged standing or sitting. So tell her to elevate her legs while sitting or standing, and dorsiflex the feet frequently. Varicose veins from venous congestion and the weight gain. She needs to elevate her legs as much as possible, wear support hose, and avoid crossing legs at the knees and standing for long periods. Hemorrhoids. Hemorrhoids can be from constipation and the slow venous return of blood from straining. Avoid constipation. Use ice packs or sitz baths as necessary, and we can use topical ointments or anesthetics. Constipation, so bowel sluggishness is from the increased progesterone. We also have a displacement of the intestines. So tell her to increase her fluid and fiber in the diet, develop regular bowel habits, use stool softeners, and exercise. For a backache, this is due to increased lumbosacral vertebrae curve due to the enlarging uterus. Use good body mechanics. Practice the pelvic tilt exercises. Avoid fatigue, avoid lifting heavy loads, and avoid wearing high-heeled shoes. or difficulty sleeping, this is because of the enlarged uterus and fetal movement. What we're going to try to do is just treat her contributing factors. So try different positions and possibly ask the doctor for a sleep aid. For leg cramps, this is from an imbalance of calcium and phosphorus and increased pressure of uterus on the nerves. So apply heat to the affected muscles and dorsiflex the feet. Okay. Round ligament pain is abdominal round ligaments stretch and they hypertrophy as that uterus rises. She can use a heating pad for relief. Flatulence, decreased gastric motility and air swallowing. Make sure to chew food completely and avoid gas-forming foods, and exercise daily. Faintness could be from a sudden change of position, which precipitates that postural hypotension. So for faintness, we might need to evaluate a hemoglobin and hematocrit to check for any anemia, and teach her to change positions slowly and to avoid standing for long periods of time. Dyspnea, there's a decreased vital capacity due to the increasing size of the uterus. So tell her to use good posture to sit and stand, sleep in a semi-Fowler's position, and sleep propped with pillows. And for carpal tunnel syndrome. So in pregnancy, there is compression of that median nerve that's precipitated by edema. So have her avoid repetitive hand movement and elevate her arm as needed. Okay, now let's talk about pain as we're going into labor. So there are adverse effects of excessive pain. Some physiologic effects include an increase in a metabolic rate and oxygen demand, increased production of catecholamines, cortisol, and glucagon, and there's less oxygen waste exchange for the fetus. Psychologically, pain can have difficulty interacting with the infant, unpleasant memories, and the partner may feel inadequate. Sources of pain include tissue ischemia, cervical dilation, pressure and pulling on the pelvic structures, distension of the vagina and the perineum. And then this picture shows you the pathways of pain transmission during labor. So you can see at the top, we have pain stimuli from cervical dilation enter the spinal cord at those top segments. And then down lower, we've got pain stimuli from vaginal and perineal distension that are traveling through the pudendal nerve and enter the spinal cord. What influences the woman's perception of pain? Well, physically, it could be the intensity of labor, the fetal position and size, characteristics of the pelvis, fatigue, and the interventions of the caregivers. Psychosocial perception of pain is affected by culture, anxiety and fear, previous experiences with pain, her childbirth preparation, and her support system. When talking about pharmacologic pain management, there is anesthesia and there's analgesia. So anesthesia encompasses analgesia, amnesia, relaxation, and reflex activity. Analgesia, on the other hand, is the alleviation of the sensation of pain or the raising of the threshold for pain perception without loss of consciousness. The type of analgesic or anesthetic chosen is determined in part by the stage of labor of the woman and by the method of the birth planned. Right? So in our first slide on pain relief, in the top right corner, you'll see a picture of general anesthesia, which is used only in emergencies. Okay, the other time you might see it is in a C-section with a woman who has a platelet count of less than 100,000. She cannot receive an epidural or a spinal due to the potential for blood loss. So she would require general anesthesia. Okay. Down in the bottom left-hand corner, you're going to see an example of systemic relief. This is via IM, sub-Q, or IV. Okay. And then starting in the top left and going down diagonally, we've got cutaneous stimulation. So this could be massage using counter pressure, also known as effleurage, a warm shower or bath. In the middle, we have got some relaxation. We're trying to decrease that muscle tension that causes fatigue and oxygen demand. And then some breathing techniques. We want to encourage that slow, deep breathing to increase oxygen exchange. All right, this slide we're looking at regional anesthesia through the epidural or the spinal. Okay, so you can see the picture on the far right shows you where the epidural is placed and then where the spinal is placed. Notice that the spinal is deeper, so it's going to have more coverage. Okay. Also in that bottom left, you're going to see what's called a pudendal nerve block. So we're literally inserting right at the pudendal nerve. This is local anesthesia that provides perineal numbness. These are for women who do not receive an epidural during labor. And we can place it during that second stage of labor, either to make an episiotomy or to repair an episiotomy or laceration. Nursing responsibilities with an epidural. So, of course, we want to watch that fetal heart rate and pattern, make sure that we have a good baseline and that baby tolerates the procedure. We want to make sure that the woman gets up and voids, and then after her epidural, she's actually going to have a Foley placed because she will not have sensation and will not be able to get up to the restroom. Okay. We're going to do pain levels before and after and, throughout labor, of course. On the top right, the nurse is responsible to assist with positioning. So we want to get the mom leaning over a pillow and trying to get a good C-curve in that spine. Okay. Don't forget maternal vital signs, especially the blood pressure. We need to get these vitals every 5 minutes in a side-lying position. Your number one major adverse effect or side effect of an epidural is hypotension. So we're checking the blood pressure, but we're also going to prevent this hypotension by using a fluid bolus. So before the epidural is placed, will you do a fluid bolus of either normal saline or lactated ringers? Okay, and make sure that after the procedure, of course, we're providing for safety. So, bed rails up, make sure she knows not to get up, make sure she knows to call. You can dim the light so she can rest. Make sure the call bell is within reach. Making sure she's got, a bedside table near her for what she needs, and a support person is always helpful. And finally, last but not least, in that bottom right, make sure that you document. Remember, if you don't document it, then it was not done. Okay. Now, of course, with an epidural, which is the most common form of anesthesia, analgesia, then there is always risks. So with an epidural block, the mom is at risk for maternal hypotension, like we said. Also, bladder distortion. The bladder can go to sleep with the anesthesia. So then we could have bladder atony. We're definitely going to lose our sensation. Okay. The epidural catheter can migrate, which means that it can become misplaced and move. And mom may have a fever from the procedure. Now, the opioids that are being administered through the epidural, they themselves can cause nausea and vomiting and pruritus or itching. All right, so since maternal hypotension is a risk, we definitely want to watch for it. If mom has hypotension, remember that your baby is not going to be perfused. So we'll watch for fetal bradycardia, absent or minimal fetal heart rate variability. Okay, those would be signs that mom's blood pressure is low and the baby is not tolerating it. Okay, so what can we do in the case of hypotension occurring? Let's turn the woman to a lateral position or place that pillow or wedge underneath her hip to displace the uterus. Okay, so we're avoiding vena cava syndrome as well. Let's see. Maintain an IV infusion at the rate specified or increase administration per protocol. We can give oxygen by a non-rebreather face mask at 10 to 12 liters a minute or per protocol. Elevate the woman's legs. Notify the primary healthcare provider, anesthesiologist, or nurse anesthetist. Administer IV vasopressors. All right, so this is where we would potentially administer some ephedrine or phenylephrine. And remain with the woman. We need to continue to monitor that blood pressure and that fetal heart rate every 5 minutes until we can get her stable again, or per the order, of course. All right, systemic drugs for labor. So you can see inhalants like nitrous oxide. That would be in your general anesthesia. We're going to use opioid analgesics. The big thing is if they are given close to birth, then your neonate could have respiratory depression. So we're going to monitor for that once the baby's born. Potentially, we might need some opioid antagonists. All right, so this is going to reverse the process of our opioid in terms of depression caused by the medicine. Adjunctive drugs are things like your nausea and vomiting medications or things like that that will help increase pain control. And then sedatives may be given as well. So for sedatives, the purpose is to relieve their anxiety, help to induce sleep. So when we have a woman that is in the latent phase of labor and it's really prolonged, or if we need to lessen the intensity of the contractions, decrease anxiety, or promote sleep, then we might use sedatives. Your sedatives would include barbiturates, phenothiazines, and benzodiazepines. This is a look at the analgesic medications in labor. You can see meperidine or Demerol is given. It is considered an opioid agonist. It does provide pain relief, gives you a feeling of well-being, but it does not have any amnesia properties. Okay. It can aid progress as cervical relaxation occurs, but if it's given too early in labor, we can actually stop the contractions. Okay, so we don't want to use it too early. Side effects for your meperidine: CNS depression, neonatal respiratory depression, again, especially if it's given really close to birth, decreased gastric emptying, increase in nausea and vomiting, inhibition of bladder and bowel elimination, and bradycardia, tachycardia, and hypotension. So there we go. Avoid the use when close to delivery. So, if we think delivery is in about, within an hour, we're not going to give it. We like to give it in that active phase of labor when we're between 4 and 7 centimeters. So that way we can hopefully prevent the progression, or stopping the progression of labor. Okay. Butorphanol or Stadol is next, as is nalbuphine or Nubain. Okay, so both of these drugs, they can be given IM or IV. They are considered opioid agonist antagonists. So in other words, they're mixed. They do have an opioid agonist effect, but they're not as strong as full-blown opioids because they do have a slight antagonist effect as well. So here we're going to use them for moderate to severe labor pain and for post-op pain after C-sections. And these two drugs do actually provide maternal sedation. Okay. The good thing about butorphanol and nalbuphine is that there's no respiratory depression in the woman or the neonate. Okay. There's less nausea and vomiting because it's a weaker opioid. But we can see confusion, sedation, hallucinations, a floating feeling, dizziness, sweating, and difficulty with urination, such as retention and urgency. Okay. We do need to check a maternal history for drug abuse. We're not going to give it to a drug-dependent woman because we don't want to accidentally precipitate withdrawal. And because we can have difficulty with urination, we are still going to encourage that she voids every 2 hours. Sublimase or fentanyl and Sufenta, which is sufentanil, okay, these are short-acting opioid agonists, which means they have a very rapid action. They work very quickly, but they don't last long, so they have a short duration. Again, for moderate to severe labor pain and post-op C-section, we need to watch for any fetal heart rate changes that could occur. We might see hypotension, respiratory depression, dizziness, drowsiness, rash or pruritus, nausea, vomiting, and urinary retention. Okay. Sufentanil or your Sufenta is widely growing in popularity because it is a more potent analgesic and less of the medication crosses the placenta. So then there's less potentially adverse complications with your neonate. And then morphine. So morphine that goes into your epidural is called Astromorph. It is an opioid agonist, of course. And pain relief during labor or from a C-section. Okay. Can cause confusion, dizziness, hypotension, constipation, or nausea. It can be used during labor, but you have to remember this can cause neonatal respiratory depression. Okay. And with all your meds, not just your morphine, of course you're doing your pain assessments. All right, so to summarize what's going on with your analgesic meds, for the nurse, we need to make sure we assess the fetal heart rate, maternal vital signs, and cervical status prior to and after administration. We're going to give analgesics at the peak of a contraction, because remember, at the peak of a contraction, the blood flow to baby is completely cut off. So that way, less medication actually transfers to the baby. We're going to assess for effectiveness and side effects, provide for safety, especially if that level of consciousness is expected to be altered. And then we always need to have on hand our narcotic reversal. All right, so our opioid antagonist, which here is naloxone, hydrochloride, or Narcan. We can use it in both the mom or the neonate to reduce respiratory depression caused by the opiates. Okay? All right, and this looks at your different types of anesthesia in labor and delivery. All right, so your first type of anesthesia that we talked about would be local. So this could be like your pudendal block, where the anesthetic is injected directly into the perineum. Okay, given in the second stage of labor, immediately before delivery, if there's been no epidural. It will help to anesthetize that local tissue to repair the episiotomy or lacerations. And it does provide rapid anesthesia. Okay. With this procedure, though, mom is at risk of a hematoma or infection. So we're going to monitor for return of sensation to that area and any increased swelling at the injection site. Okay. Regional anesthesia. This is where they're putting their pudendal block. We're using xylocaine. Again, second stage of labor for repair. Watching for sensation to the area, increased swelling, signs and symptoms of infection, and urinary retention. Your epidural block, with the epidural, an anesthetic is injected in the epidural space. Okay. First and second stage of labors, when it's used, we can use it for both vaginal and cesarean births. It has the potential to block 100% of the pain, even though sometimes it is not effective. Okay, rapid onset lasts 60 to 90 minutes. Let's see. Most common complication, hypotension. We know that. Other side effects, nausea, vomiting, itching, respiratory depression, alterations in that fetal heart rate. And again, if we give it too early, it could slow our labor progression. Okay, and you guys can read the pre and post care. Another regional is your spinal block, done in the second stage of labor or for a C-section. Adverse effects are similar to the epidural. The only addition is if we have any leakage of spinal fluid, that can cause what we call a spinal headache. Okay, and I'll let you guys read your nursing interventions there. And then there's your general anesthesia, mostly used in an emergency section. If she's going under general, she's definitely going to need to be intubated. And this has the highest risk of fetal depression, uterine relaxation, and maternal vomiting and aspiration. Okay, your summary, we're going to preload with IV fluids before we do any kind of anesthesia. We're going to give pre-op meds before our C-section. You're responsible for positioning during the procedure. We can displace that uterus, kind of move it over after the procedure for better circulation through that placenta. Of course, we want to monitor vital signs. Typically, it's every 15 minutes. Reposition for an even block. Okay, so it's kind of like if it all goes to the right side, turn mom on her left, so hopefully it will move to the left side as well. Always watch for bladder distension, and we'll catheterize as needed. And continue your pain assessments and communication.